Please welcome to the stage Michael Ward, Vice President of Public Affairs and Government Relations at the Alliance for Aging Research, joined in conversation with Joe Ruffalo.
Michael, good to see you. Thank you for being here today. We just heard congressional perspectives on the Inflation Reduction Act, but stepping back from the long-term considerations, what should all Medicare beneficiaries be on the lookout for heading into open enrollment in October?
Yeah, well, it's really kind of a game changer this year. We're seeing the two major provisions of the IRA go into effect, which Congressman Peters talked about, the $2,000 out-of-pocket cap. So this is the first time ever in the Medicare program that there's going to be an upper limit on what Medicare beneficiaries actually pay for prescription drugs. So, in prior years, we would see, patients that had expensive drugs, such as in the oncology space, they might spend $5,000, $6,000, $7,000, even more per year, and so that's not really kind of sustainable from a patient perspective. So that new $2,000 limit is going to be really important. The second benefit that we're excited to see is that for any cost below $2,000, that beneficiaries will have the ability to pay that through zero interest payment installments, and this is called the Medicare Prescription Payment Plan. This will, I think, $2,000, still a lot of money, right? So I think coming out of your paycheck all at once or the money that you have in your bank account is a significant barrier. It may cause issues in terms of whether someone decides to fill their prescription or not. And so we're hopeful that this program will, allow people to actually be able to go up and afford their medications, because they don't have to pay at the pharmacy counter, but they'll be billed later by their insurer. So on the flip side, though, I think there's some things to be aware of as well. There are real challenges with the way that the Inflation Reduction Act, some of the pay for, is not just price negotiation. It's for the beneficiaries that had expensive drugs that they're paying those $5,000, $6,000, $7,000. A lot of that financial risk is being shifted to insurers. And so insurers now kind of have an incentive to try to figure out where to make up that money on their own bottom line. And unfortunately, I think one of the things that we're likely to see is increased utilization management. So I think we've probably all experienced where our doctor needs to call in and get approval for a drug. That's called prior authorization. And a more severe flavor of that is called step therapy, where your doctor may prescribe you a drug, but your insurer says you need to try these other drugs first, and they have to not work before you get the drug that you're initially prescribed. And so it's going to be really important going into open enrollment with all these changes happening for beneficiaries to examine to see if the drugs that they're on are covered and if they're affordable. Honestly, Joe, there's not a whole lot of turnover. Like once a Medicare beneficiary picks their drug plan, when they end the program, they usually stay on it. But with all these changes, it may not be the case that the plan that people have been on is necessarily like the best option for them moving forward. And so we really are encouraging people to shop around this year. If folks are watching and want to take away, I think it's really important in their open enrollment for individuals in Medicare to shop around and to also make sure when they're doing that, use Medicare Advantage Plan Finder, call their plans to make sure that the drugs that they take are covered, and make sure also that they're not subject to kind of these additional requirements that may interrupt their access to care.
The Alliance has worked to raise awareness, and you mentioned some of these, the out-of-pocket maximum and Medicare Prescription Payment Plan, both of which will be fully implemented in 2025. But what level of awareness is for all of these?
Yeah, I think it's a challenge right now, quite frankly. It's the $2,000 cap is less of an issue because it's an automatic thing. So if an individual spends $2,000 out of pocket, then they'll automatically be cut off and they won't have additional out-of-pocket expenditures. So that's relatively easy in terms of, if there's not appropriate education done, that that it won't have kind of an adverse effect. I think the bigger challenge is around the Medicare Prescription Payment Plan, because unlike the cap, this is an opt-in benefit. You have to tell your insurer that you actually want to use this plan. And you have to do it before you get to the pharmacy counter. Like if you go up to your local Walgreens and say, hey, I'd like to use this payment installment plan, it won't, you'll have to have to come back later, basically, because it requires at least 24 hours before you fill a script for that to go into effect. And so this is going to require a lot of education. CMS is doing some, but honestly, I think that they may not have the budget to do as much as they may hope. And so groups like the Alliance and other patient groups are doing efforts to help raise awareness, creating our own materials to come alongside what Medicare is creating. But it's really going to take not just patient advocacy groups, but many others in the healthcare space to really make sure that beneficiaries are well positioned to take advantage of these new benefits that the IRA provided.
Manette Health just released a white paper today that was sponsored by the Alliance that looks at issues you mentioned around incentives for prescription drug plans to change what drugs they are covering. What else is covered in the report that we should all be aware of?
I think the high-level takeaway, and there's an executive summary for those in the room and a QR code that you can go to the report on the back, is that kind of with all these challenges that we talked about, both with plans having more incentive, they're at higher financial risk due to those changes that are coming this year. To be honest, we're also seeing some similar dynamics at play with the drugs that are subject to price negotiation. There's going to be some incentives to move these drugs around in a way that may make them more expensive or harder to access for beneficiaries. And so this report really digs into those issues, explains kind of what's behind the factors that are driving this. And I think one of the things I'd like to take away from the report is that there are actionable things that CMS can do now, that the Medicare program can do now. It doesn't take congressional action because we know that is a long road to hoe, and given the current political environment and that we're in an election year. And so these are actionable things. It's like greater transparency, for beneficiaries. That way they can see if there's like utilization management techniques that are being used by insurers. It's also things like appeals. So if you are denied access to a medication by your plan, you can use an appeals process by Medicare, but very few beneficiaries use this. It's cumbersome, but if you do use it, you tend to have a very successful experience. So making that less cumbersome, more accessible, and also just for the prescription drugs that are subject to negotiation, which kind of by definition, Medicare is saying they're paying a fair price for, that they're placed on a tier within a drug's plan formulary that's not overly expensive for patients. And so I know that I was excited to see Manette's findings and some really great recommendations, and I know that we'll be asking CMS to act on some of these, and we hope that others will as well.
Excellent. What else should we know about how CMS is implementing drug pricing changes before we go?
Yeah, well, I'll say that Representative Peters took a lot of the points I was thinking about in this space because, with whether it's the IRA or any other huge piece of legislation, there's just so many moving parts that there's bound to be something once you get in there and start implementing it that it has some consequences, some aspects to it that didn't quite turn out the way that we wanted, right? And so I know that Representative Peters talked about the difference between a small molecule drug, so these are like the drugs that you would pick up in a pill form at a pharmacy counter versus drugs that are administered in a doctor's office that you have to go there from we represent older adults, and so if you're older, you may have more mobility issues, challenges getting to a doctor's office. Frankly, those medicines also tend to be more expensive than pills, and so I think that there's just some incentives there that we're concerned about because those drugs, those pills, are actually disadvantaged compared to those that you receive in a doctor's office, and so I know that there is some. And I think we're just concerned, long term also about what the impact that this will have on research and development. Really, we hope that research and development is guided by science. It's guided by kind of what is the best mode of delivery, both in terms of efficacy of a drug, but also in terms of convenience for a patient. And we don't want that to be overridden by payment incentives. And so, we're also seeing similar issues in the orphan drug space for these rare diseases. That if you do initial research for an additional condition that is approved by the FDA, however, if you're approved for a second condition, then you're subject to negotiation. So it it really disincentivizes doing that additional research into an area where a drug could be really effective and it could be a cure or really helpful for that patient population. So I was really encouraged. I mean, I know the challenge around the IRA is that it's still being implemented. There's reticence to revisit it. And while it's still being implemented, there's political challenges, but it was really, I think there is a developing consensus and awareness, as Congressman Peters noted, even among even like the Democratic side, which passed the IRA, that there are some tweaks that are necessary, and that we are hopeful that that momentum will continue to build in the years to come to make those changes.
That's great. Well, thank you, Michael. A lot of great information. Appreciate your insights today.
All right. Thanks, Joe.
Thanks.